So an ultrasound beam travels through tissue layers, and the amplitude of the original signal becomes attenuated as the depth of penetration increases. And remember that attenuation is an energy loss. So as that sound wave is going through tissue, it loses energy. It can either lose it through absorption, which is lost to body's heat. You can lose it through reflection, which is where it bounces off tissues. And the greater the impedance, or the greater, so bone versus tissue versus muscle, the greater the impedance, the greater the reflection.
Hello and welcome back to CRNA School Prep Academy podcast. I am so excited for today's topic, which is going to be on ultrasound physics. I know, it sounds complicated, right? And what's even more special about today's episode is it's going to be taught by the one and only Dr. Jennifer McPherson. Dr. McPherson is a distinguished certified registered nurse anesthetist and a retired U.S. Navy commander. Her remarkable career includes serving as an assistant professor and clinical site director at the Uniformed Services University of the Health Sciences School of Nursing in San Diego. In her role at the USUHS, Dr. McPherson was responsible for both didactic and clinical education of Phase 2 of the Student Registered Nurse Anesthetist. Her expertise spans from several critical areas, including pain management, critical care, ultrasound-guided regional anesthesia, and simulation. Dr. McPherson contributes to the field of nurse anesthesia, and her dedication to teaching have made a significant impact on the next generation of nurse anesthetists, and she currently serves as the program director of Mary Baldwin University. So without further ado, let's go ahead and get into some ultrasound physics.
Hi, I'm Dr. Jen McPherson. I am the program director at Mary Baldwin University. Today, I'm going to go over the basics of ultrasound, a little bit of ultrasound physics, a little bit about probes, some terms, knobology, just kind of the basics to kind of get you going and get you an idea of how we use and why we use ultrasound-guided regional anesthesia in our practice. So when I first started doing anesthesia back in 2001, we used a nerve stimulator to do all our ultrasound-guided regional anesthesia, which I know a lot of you are kind of familiar with it. It's where we use ultrasound, we use a needle, and we inject local anesthetic into an area that will numb that body part. So whether it be numbing an arm for hand surgery or numbing an ankle for ankle reconstruct surgery, even if it's doing something with the abdomen when we're doing abdominal surgery. When we use ultrasound, it gives us a real-time picture of what we're looking at. When we were using nerve stimulators, it only allowed us to kind of know about where we are with the needle. Now we can see the anatomy real time. We can notice any aberrancies, and then we can see how our local distributes around the nerve. So, what exactly is ultrasound? Ultrasound is a form of mechanical sound energy that travels through a conducting medium, tissue, and then gets reflected back to form an image. So again, all it is you have this sound wave going down, there's an impedance or something it bounces off of, and it comes back to form an image on the screen. That's all it is. First, we're going to talk about the waveform, and this really gets into some of our ultrasound physics. So we have a waveform, we have a compression and a refraction. Pressure is the compression and the refraction. The wavelength is the distance between two adjacent points. So if you have this compression to this compression, that's a wavelength. The frequency is a complete cycle of a compression and refraction, which is a hertz. So now you have your complete waveform. So when we talk about high frequency and low frequency, as you can see in this picture, the higher the frequency, it produces a shorter wavelength. And remember, we said the distance is between 2 points. So you can see this is a shorter distance, which causes a higher frequency. For a lower frequency, we have a longer wavelength. So you can see the distance here is longer from point to point, and that gives us a lower frequency. When we look at a probe, down here in this bottom part, we have piezoelectric crystals. So those piezoelectric crystals are what form the ultrasound waves. Here you have your probe. So you have the transducer, which converts the electrical energy to mechanical energy. And remember, we talked about that mechanical energy as the ultrasound energy. So you have your probe. At the end of your probe, you have your piezoelectric crystals. Those transmit and take the electrical energy from the probe. So you have the cord. Let's see, you have your cord coming here, then you come down. So you have your electrical impulse coming down through here, and then you have your piezoelectric crystals right in here. These crystals transition it into a mechanical energy, which is your sound energy or your sound waveform. Here's your impedance, which is an organ or what it bounces off of. And then you have your returning beam, mechanical energy, your returning sound wave, going into where the piezoelectric crystals are, which transfer it back to an electrical impulse, which then take it back to the screen, which then gives you your image. So as it goes down, it's an electrical energy, goes into the transducer, then it becomes a mechanical energy through those piezoelectric crystals. So an ultrasound beam travels through tissue layers, and the amplitude of the original signal becomes attenuated as the depth of penetration increases. And remember that attenuation is an energy loss. So as that sound wave is going through tissue, it loses energy. It can either lose it through absorption, which is lost to body's heat. You can lose it through reflection, which is where it bounces off tissues. And the greater the impedance, or the greater, so bone versus tissue versus muscle, the greater the impedance, the greater the reflection. And we'll talk a little bit more about that in a minute. And then scattering. And that's when the ultrasound wave encounters something smaller than the wave, like fluid. And that's why when you look at a fluid-filled area like this, it causes that mechanical energy or that sound wave to scatter, and there is actually no reflection. So that's why it looks anechoic or black. And we'll talk a little bit about hyperechoic, hypoechoic, and anechoic. But remember, when we talk about attenuation and energy loss, that also has to do with the impedance. And the impedance is when it hits and causes a break in that sound wave. So here we have 3 different types of probes. We have our linear, our hockey stick linear, and our curved array. The linear probe just goes straight across, as you can see, and the piezoelectric crystals come straight down. The curved array, the piezoelectric crystals go out at an angle, and we'll look at that in the next slide. Important things to note is that the linear does give you that straight across view. It has a higher frequency, so the depth doesn't go as deep, but it gives you a very clear view. The curved array, on the other hand, goes deeper. It has a lower frequency, but your visualization is not as clear. So let's look a little more into this. So now we're talking about angle of incidence and angle of incidence. And we just finished talking about the linear versus the curved probe. And when we talk about angle of incidence, we talk about it at a 90-degree angle. So 90 degrees gives you that nice strong echo. If it's less than 90 degrees, you're going to get a weak echo, or if it's greater than 90 degrees. So we want to try and keep it at that 90-degree angle as much as possible to get our best visualization, whether that's pushing down on the skin and tilting it toward or leaning it toward the object, whatever that takes. So when we talk about needle driving and we talk about the linear probe and angle of incidence, you can see here, we drop a needle and you can see this is angle right here is much less than 90 degrees. So your visualization is just not going to be as good as if you could drive that needle in a little further down this way. And now we see the needle on the linear probe, and because you have those piezoelectric crystals that shoot out sound waves all the way on this curved area, it gives you a little better angle of incidence and a little better intonation, angle of incidence and visualization.
Hey future CRNA, another daily dose of inspiration along your CRNA journey. This success story starts with these words. With all the happiness in the world, I am so excited to say I was accepted into CRNA school, into my top choice school. My journey has been a roller coaster, to say the least. I'm so blessed for this amazing opportunity. Thank you, CRNA School Prep Academy, for all your amazing resources. Your support resources have helped me during every step of this process. I wish everyone on their journey all the strength and positivity. I say with the utmost certainty that if you want it, you will get there. If you envision it, you will have it. I'm going to be a CRNA, you guys. I can't stop crying. So I wanted to share this because some really inspirational words and motivation from the student is that if you envision it, you will become it. If you believe, you will achieve. And while I know some of you may be full of fear and doubt, this is the transition that needs to occur in your CRNA journey. Really, we are unstoppable as human beings. If we really want something, we will go after it at no avail, right? So I hope that leaves you with this positive reinforcement that you are doing your best. And as long as you keep showing up, you're going to find success. So no matter what experiences you think may hold you back, just embrace it, face it head on. You can do this. I'm rooting for you. Let's get back to the show.
So again, when we're talking about structures that allow for sound wave transmission, we talked about anechoic, hypoechoic, and hyperechoic. So when it's black, it's anechoic. And we talked about that scatter, and we talked about vessels and fluid. And that's what we're talking about with our anechoic. Our hyperechoic, the same. The hyperechoic means there's little to no transmission. And you can see right here where this bone is, it's causing this huge impedance, and that reflection is that very big reflection coming back where there's no transmission because of it, causes that nice hyperechoic white appearance. Whether it's in muscles, whether it's across bone, whether it's through different structures, we have that very bright reflection that gives us that hyperechoic appearance. Moving on with our hyper, hypo, and anechoic discussion, we have the anechoic that we talked about that's basically where it kind of scatters and there's no reflection and there's no impedance. And because there's no impedance, there's no reflection, and it's just a black circle. Our fat tends to be a hypoechoic, which means we have there is some reflection, there is some impedance, but it can be kind of a light blackish with some hyperechoic areas and lines going through it. And that's especially true of our muscles. Our muscles have those hyperechoic lines within the hypoechoic tissue. And then our nerves are also a mixture, depending on where they're located in the body, how much impedance there is, how thick the nerve fibers are, will determine whether they are more of a hyper or hypoechoic type structure.
Hello, future CRNA. Coming on with some inspiration and to hear from a current CSBA student. CRNA school, here I come. With the help of this fantastic group and a little bit of luck, I thank God for allowing me to say I got into CRNA school. I start my dual DNP CRNA acute care NP program this fall. I am stoked to be part of such an incredible profession. I cannot thank CSBA enough for all the services, online mock interviews, tips on successfully getting into CRNA school. We are so proud of you, Abel. Congratulations. I hope you guys enjoyed, and now let's get back into the show.
So now we're looking at orientation, and we have what we call a long axis or in plane, and we have a short axis, which is out of plane. That gives us the appearance of the tip, but this may not actually be the tip because it could be over here, but it still just dissects that needle when you're looking at a short axis or out of plane view versus your long axis and in plane view gives you a nice appearance. When we look at coming in, this is called in plane view, and this is out of plane view. And what you see right here is this tip going in versus your needle. So we also call this a short axis view. And there's the tip of the needle, there's your out of plane, there's your long axis view with the needle coming down this way and coming in, or your in plane view where you have the probe and the needle coming in plane. We'll briefly talk about ultrasound machines. Here is what we usually see in anesthesia. Here's another one we see in anesthesia. These are ones that providers have started carrying around a lot. They're portable, they're easy to use. You can hook them up to an iPhone, a tablet. We have both at our program. We have the basic big huge ultrasound machine, and then we have the handheld ones. And then finally you have the one that we do not like to use, and this is the one they use for GYN. And if you have a radiology tech come and they bring their nice big monster of a machine with them, or when you go and you have an order to have an ultrasound done through radiology, they tend to have the big giant machines. We'll touch on knobs real quick. Really, we have gain, frequency, depth, focal length. The two that you will use the most are gain and depth. Depth lets you visualize things deeper. Gain makes it brighter or less bright. Please don't confuse gain with being able to see something clearer. A lot of people work on the gain to see it clearer, but all that does is make it darker or lighter. Sometimes making it a little lighter can help you see, or making it too dark makes it too dark to see, but you want to find that fine distance between the two. When we're talking about depth, we're talking about focal zone. So when we increase or decrease our depth, so 2 centimeters versus 3 centimeters, right here in the middle of the screen is where you want the object that you're trying to look for. So if you're looking for a nerve, here's your nerve right here. And you put your nerve in the center of the screen because the beam reflection in the center of the screen is considered the focal zone, which is the optimal place to visualize your nerve. Little bit about color Doppler, not a whole lot. We won't get into the weeds, but basically if you want to distinguish between a vein and an artery, you're going to push on it. When you push on it, you see a vein collapse and an artery keeps its form. You can use color Doppler and it will show you blue for vein or red for artery, but that's not necessarily true because what we have is what's called a Doppler effect. And the Doppler effect and the angle of inclination has to do with which way the blood is flowing and whether it's going away from the heart or towards the heart. And that's actually how it perceives it, is red or blue. So if you're looking at this vessel and you see they're holding it this way and they're holding it this way, the flow, the way it's coming toward the probe, is showing blue. If you hold the probe this way, it shows the blood flow going this way, but this way might be considered red for the artery. So it all depends on the angle of inclination. So if you hold a probe, you want to hold it so that you know that the blood flow that's going back to the heart, and the angle of intonation will show it blue versus red. And again, those are kind of some in the weeds stuff, but no, the real way we want to know between an artery and a vein is whether it compresses or not. Talk briefly about patient positioning and ergonomics. You want the patient to be sitting comfortable, but then you also want yourself to be comfortable. You want to ensure that you're lined up correctly. So when I say align, needle, probe, and machine, this is what we're talking about. He has the machine over here, he has his probe here, and he's here. So he's perfectly aligned to be able to watch his needle driving and watch the ultrasound machine as he goes. When we look at clearing up, trying to visualize something and making it clear, we talk about tilt, alignment, and rotation. So we can call it ART, the alignment, rotation, and tilt. Alignment means whether you're lined up, rotation means rotating, and tilt obviously means tilting. So those are ways that you can clear up your visualization. So that's the down and dirty of ultrasound physics. It's very similar to the lecture that I give our residents in our program. Again, I'm Dr. Jen McPherson. I'm the program director for Mary Baldwin University. We do have open houses July through December. The second Tuesday night of every month at 7 p.m. You can go to our website and click on it, and you're more than welcome to join us and not only learn about our program, but learn about how to interview, what we look for in interviews, the interview questions, what type of questions we ask. And those tend to be standard across all programs. We also talk about our requirements and our sites and everything in our faculty, but everything we give you will also help you across the board with all programs. So please feel free to join us for an open house and learn about our program, and then learn about how to apply for programs in general. So thank you for listening, and I hope to see you at one of our open houses.
Hey, future CRNA, as always, I appreciate you and your loyalty. Thank you so very much for tuning in this week. I'd love to hear from you, so screenshot this episode and share it to your IG stories with your biggest takeaway. Don't forget to tag me at CRNA School Prep Academy so I can personally thank you. Be sure to head over to CRNASchoolPrepAcademy.com to check out our blog and gather free resources to help you along your CRNA journey. Stay strong, and I'll see you next week.